We are live.
Good evening, everyone. Welcome to the iFocus online lecture number 485, Refractive Surgery module number 36. Today's topic for discussion is complications and management of refractive lens exchange, which will be taken up by Dr. Shreya Tyagi, ma'am. So the moderator for today's class is Dr. Tushar Grover, sir. He is a cornea, cataract and refractive surgeon. He has done his post-graduation from Arvind Eye Hospital, Madurai, and fellowship from Narayana Nethralaya, Bangalore. Currently serves the medical director of Vision Eye Center and consultant at Sir Gangaram Hospital, New Delhi. He has delivered over 150 invited faculty talks in national and international conferences. So is the recipient of awards in various national and international conferences, which includes ASCRS, ESCRS, AIOS, and DOS. Sir has various publications in journals including JRS, IJO, and DJO. So he's also the reviewer for journals such as IJO and AJO. He is the section editor of Refractive Surgery column in the DOS Times. We welcome you, sir.
Thank you, Dr. Sarveen. Thank you for having me.
Chairperson for today's class is Dr. Bhupesh Bhatkuti, sir. He has done his MBBS from Armed Forces Medical College and has received distinction in ENT and ophthalmology as well. Sir has done his MS from MUHS Nasik in 2010. He has done DNB from the NBE board in December 2010 and was awarded a gold medal in the same. So has done his fellowship in cornea and refractive surgery from PGI Chandigarh in 2016. Sir is employed in defense services and is presently based in Pune. Sir has over 18 years of experience as an ophthalmologist, has worked in various prestigious institutes like AFMC, Command Hospital, Pune, Lucknow, and Chandigarh. Sir is a recognized teacher, a professor with MUHS at Nasik. Sir has conducted over 1,000 corneal transplants, including DSEC, DMEC, and DALC surgeries. Sir has special areas of interest in cataract and keratorefractive surgeries. He is also the reviewer of reputed medical journals such as MJFI, has numerous publications, international as well as national. We welcome you, sir.
Thank you, Dr. Sarveen.
The speaker for today's class is Dr. Shreya Tyagi, ma'am. Ma'am has done her MBBS from Sikkim Manipal Institute of Medical Sciences. Ma'am is a gold medalist in MS, has done her MS from Gandhi Medical College, Bhopal. So, ma'am has done her fellowship in cornea and cataract surgery from Shroff Charity Eye Hospital. She has been trained in refractive surgeries under Dr. Rupal Shah, ma'am. She is also survey doctor in rapid assessment of avoidable blindness 7. Currently, she is the consultant at Center for Sight Eye Hospital, Ghaziabad. She has performed more than 3,000 cataract surgery procedures, including complicated cataract surgeries. She has trained many fellows in cataract and penetrating keratoplasty surgeries. Ma'am has numerous presentations and publications in prestigious national and international conferences and journals. We welcome you, ma'am. Over to you, ma'am.
Thank you, Suveen, for such a generous introduction. I'll start sharing my slide now.
Yes.
Can you please stop sharing?
Yes, ma'am.
Yeah. Can you, okay. Is it visible now?
Yes, ma'am, visible.
Okay, I'll start with it. So today, refractive lens exchange. This is in continuation with the last topic that we had. We'd be covering the complications and management. So I'll be starting from the beginning. That is, we have pre-operative complications and then intraoperative and post-operative. Coming to pre-operative, it all depends upon an accurate biometry, which is the key for post-operative success in these procedures. So for that, we have a ESCRS calculator, which takes out the mean of all the formulas because we have numerous formulas for calculating. So optical biometry is much more better than ultrasound biometry. The newer formulas, especially for axial length more than 28 millimeters, we are using is Evo, Kane, Olsen, and Barrett. The older formulas work too, that is SRKT, Holiday, and Haggis. However, the ESCRS calculator will take the average of all the formulas and give us an IL calculation, which will have the least amount of error present. Also, pre-operatively, it becomes mandatory that we do for
Shreya ma'am?
I don't think she is able to hear us. Dr. Shreya, can you hear us?
Ma'am, your presentation is not visible. Ma'am, your presentation is not visible.
Is it visible now?
Yes, ma'am. Now it's
Okay.
visible.
All right, all right.
Ma'am, we just missed the first few slides. We couldn't hear you.
Okay, did I start with intraoperative already?
Ma'am, we lost you around at
Oh,
around second or third slide.
okay. Pre-operatively, this is where we were. Can I start from here?
Yes,
Yes, ma'am.
doctor, please.
Okay, all right, okay. So pre-operatively, biometry is really important. That really determines the operative's success, and that's what I told, that there is a ESCRS
जो
calculator.
लैपटॉप है उसमें कैमरा नहीं चल रहा तो मैंने उनको एक जगह लग गया
Am I audible now?
जिसमें लैपटॉप है
Am I audible? Can I continue?
Yes, go ahead.
Okay, okay. I was talking about the ESCRS calculator, and this is what it looks like. Moving on, we have to avoid RLE in these particular patients. That is, the ones having advanced peripheral degeneration, young eyes with no PVD, intense lacquer cracks, or myopic CNV, and presbyopic eyes. Intraoperatively, we have to take care of few things. That is the wound. That is the incision that we are creating. It has to be watertight, of about 2.5 millimeter or less. It has to be clear corneal and at least 1 millimeter from the limbus on the steepest meridian. It cannot be too short and should not be that long as well. In eyes with high myopia, the anterior chamber depth and stability is compromised, so it is necessary that we use dispersive OVDs. We have to take intensive care of the capsular axis. That it should be well centered. It should be a little less than the optic. It should cover the optic 360 degrees. An irregular rhexis may lead to capsular fibrosis or PCO or IOL decentration. Also, a runaway rhexis may cause PCR. So it becomes imperative that we use femtolaser in capsular access wherever possible. Also, the irrigation fluid should be of best quality, preferably BSS with glutathione, as it is a balanced pH solution. Also, it can be used for surgeries which have a longer duration. Post rotation, post hydrodissection should be avoided because, especially in the case of myopes, the zonules are weak. We have to keep the bottle height a little low, and a low power setting has to be used. That is with phaco power with moderate aspiration and vacuum. Simple cortical aspiration can also work. After that, we have to polish the capsule, and there has to be a thorough cortical cleanup. Sudden decompression should be avoided, and we should not be taking out our instruments suddenly out of the eye, or there has to be a replacement, a visco fluid replacement at every stage. Choice of IOL, whatever IOLs we are using, they should be posterior square edged, designed with haptic. And the IOL selection positioning is important. That is where we have to put a EDOF, or where do we have to put a multifocal, that has to be decided. Also, we can opt for larger optic IOLs with special designs, which can reduce the risk of tilt and decentration. Accurate centration has to be there so as to avoid the induced astigmatism or other visual distortion that can strain the retina. So post-operatively, coming to complications, especially in myopes, the first one, however, not most common, but the most dreaded is a retinal detachment. that is said to occur in about 1.5 to 8% of the people. It is the most vision threatening, and the causes, it usually occurs in patients which have a higher axial length that is greater than 26 millimeters, or patients with age less than 50, males, Caucasians, and which have pre-existing retinal degenerations like lattices or holes or tears. Also, if in case there are volumetric changes in the vitreous, that is intraoperatively, it can also lead to vitreous traction and vitreous degeneration. We have to try to avoid intraoperative PCRs. And though NDI capsulotomy can be done, however, Javid et al. Says that they reported a 3.9-fold increase in risk of RD post-YAG capsulotomy in their study. So how can we prevent RD in myopes? There are a few things that we have to take care. That is, preoperatively, there has to be a thorough retinal examination, which will include the dilated fundoscopy and OCT to assess the retina's health, especially the peripheral areas have to be looked through. If in case there are pre-existing holes or tears or thinning, there has to be a prophylactic laser photocoagulation done to seal those potential breaks. Ultrasound biometry was done previously, but it's always better to do a IOL master because these eyes may have staphylomas, and IOL masters usually have a fixation check. We also have to be extra cautious in patients with axial lens over 26 millimeters. So there is a retinal detachment risk calculator, which works on, like, this is the link that we can always go to and check. And it usually takes these parameters into consideration, that is age, refractive error, whether or not there is a presence of lattice degeneration in PVD, the gender, and the axial length. So it basically calculates what might be the risk of RD within a year and in the coming years. So, in myopes, surgical technique, as discussed before, we have to minimize the vitreous disturbances by using gentle technique while handling the PCR. We have to avoid the PCR wherever it is required. We may use capsular tension rings because that then stabilizes the capsular bag, ensures that IL centration is there, and there is minimum risk of complications. Uh, then, in some cases, we can also do a pre-operative vitrectomy. That is where patient is a high-risk patient and RLE is done, and there is a significant vitreous degeneration or retinal breaks are present. A pre-operative vitrectomy can be done to remove the vitreous body and prevent the tractional forces from causing a detachment post-surgery. Post-operative care, there has to be a frequent follow-up, and the patient has to be well educated about the occurrence of flashes or floaters or sudden visual disturbances or the feeling of a curtain falling. So in that case, we have to tell them to come and show as soon as possible, so early detection and intervention can be done. Other complications in myopes are myopic macular degenerations, cystoid macular edema, posterior capsular opacifications, halos and glares in CNV, and ARMD. I'll be taking them one by one. Coming to posterior capsular opacifications. So it's the most common long-term complication in RLE, and it usually happens because of the epithelial cells remaining in the capsular bag, which proliferate and then they lead to the clouding of the posterior capsule. So how can they be prevented is that, like I told, that we can use a square-edged hydrophobic IOL, and even the anterior capsule polishing should be done to remove the residual lens epithelial cells, and the anterior capsular axis has a diameter which completely overlaps the anterior capsule. In case the PCO does develop, in that case we can do a Nd:YAG laser capsulotomy, but studies have shown that even capsulotomy will increase the chances of RD in these eyes. So there has been a study done which says that we can combine it with the primary posterior vitrectorexis. This is very much similar to PCC that we do in pediatric patients. So the reasons that they gave was that usually YAG capsulotomy is responsible for a number of complications like IOP elevation, IL pitting, CME, and retinal attachment. And during a 7-year follow-up, Collin et al. Also found that around 61.2% PCOs are necessitating capsulotomy after CLE for high myopia. The similar thing was found by Fernandez Vega et al., who reported that Nd:YAG laser capsulotomy risk was 77.89% following RLE for the correction of high myopia. And many studies have reported that there are increased RD rates in these Nd:YAG capsulotomy done of around 0.5 to 3.6%. Also, the laser energy may induce vitreous liquefaction, PVD, or both, and that might lead to induction of new breaks or enable the pre-existing breaks to progress to RD. Also, RLE is usually done in young age, and it is relatively seen that the young patients with the RLE and with the PCO created, they'll need more energy, laser energies for capsulotomy. And there is a collinear correlation between the complication of YAG capsulotomy and the laser energy levels. So this was the reason that they gave for doing a vitrectorexis in the very first place. So this is what it looks like, that in the center they have done a small PCC. Then there is one more study that says that we can also peel and aspirate the Escherichia pearls which are formed. As in that we are taking the patient again in the OR, and then with the help of a simple hydrocannula, maybe we can just flush the posterior capsule, or they have one more cannula which can be attached to a 5 cc needle, and through that wash can be given. Coming to the next complication, that is myopic macular degeneration. So it's a little bit of pathophysiology that I've tried to explain, that there is a axial elongation usually in a myopic patient, which leads to thinning of retina and choroid. As a result of which there can be thinner retina, and the choroidal vessels can become atrophic, reducing the oxygen, finally leading to chorioretinal atrophy. This then leads to macular scarring because there is a progressive thinning of the retina. Also, in severe cases, the retina may attempt to compensate this damage by forming abnormal new blood vessels, which is known as choroidal neovascularization. Usually, it is seen in the case of pathological myopia, that is, myopia greater than -6 diopters. What might be the causes of MMD progression in RLE? So post-operative change of axial length is there. That is, the IOL is being placed, and then there might be changes in length of the eye in the refractive state, which might lead to exacerbation of or accelerate, or it might accelerate the macular changes. Also, there is a loss of accommodative function, as a result of which there is a change in biomechanics of the eye that exacerbate the stretching and then already elongated myopic eye. So this can further lead to thinning of the macula and increase the vitreous fraction. Then there are also vitreous changes in vitreous retinal attraction, which is happening as in the case of PVD is getting induced. Also, because of all this anatomical all of this thinning and PVD, there can be a macular hole formation that might happen. So how would a MMD patient that is coming after RLE is that we have to educate him that there can be a decreased visual acuity, or there can be a distorted vision, that is metamorphopsia can be there. And with the straight lines appearing bent or wavy, they can be scotomas, and there can be like that is blind spots and areas of vision loss in the central visual field. Or they can be even decreased contrast sensitivity and flashes and floaters. So for avoiding MMD, as told before, we have to do a preoperative screening, which will be comprising of the retinal examination, preoperative counseling of the patient. Just in case there occurs a CME, in that case, an anti-inflammatory medication in the form of corticosteroids or NSAIDs can be given. In case CNV is there, anti-VEGF therapy will have to be administered, and vitrectomy can be done in the case of macular hole formation or retinal attachment. It becomes imperative here also that there has to be a customized IL selection. That is, we can avoid multifocal ILs in patients with retinal damage. And there has to be a precise IL positioning so as to reduce the risk of IL tilt, which can exacerbate the retinal stress. Another complication, that is, there can be intraocular lens dislocation and decentration. As told before, it has to be taken care of by keeping the capsular axis on point. That is, which can be done by doing femto. Also, there has to be IOs used with appropriate fixation mechanism, like the square-edged ones. Coming to cystoid macular edema, starting from the pathophysiology, why does that happen? That majorly happens because of the increase of inflammatory mediators as a result of any surgical trauma or inflammation, and then prostaglandin production, which leads to increased vascular permeability, and the fluid might accumulate at the macula. Also, posterior capsular rupture or incomplete capsulotomy can increase the risk of CME due to inflammatory cell migration. Also, in the case of pre-existing retinal pathology like diabetic retinopathy, retinal vein occlusion, and retinal vascular anomalies, this might happen. CME can also develop in cases where extended surgical time has been there, as it results to vitreous retinal traction. And it can also happen because of hyperopic shift or inaccurate IL power. because there occurs a significant hyperopic shift post-operatively if in case the IL power is inaccurate or if there is capsular bag instability, which can lead to mechanical stresses on the retina contributing to CME. In that case, we have three options for management. That is either we go for NSAIDs, topical steroids, anti-VEGFs. There are few studies which are also advocating that the patients who have undergone RLE in both the eyes would always prefer dexamethasone implants to topical manners of treatment. There's a study going on right now, which is called as myopred, that is myopic pseudophakic retinal attachment. It is studying the influence of PVD on retinal attachment after the lens surgery, that is RLE. It will include around 618 patients with axial lengths of 25 millimeters or longer, and this is a 5-year study. It's still going on. Coming to complications in hypermetropes. So again, the myometry plays an important role. The most common in them is posterior capsular opacification because fibrosis occurs much more in smaller eyes. Post-operative rise in IOP because of congestion of and smaller size of all the organs, all the structures inside the eye. Then they can be intraoperative corneal edema because there's not much space to operate, and there are chances of suprachoroidal hemorrhage also. There's a chance of retrobulbar hemorrhage also in these cases while giving the block. So it's imperative that we try to do it in subtenon block. Firstly, increased risk of glaucoma because there are small anterior chambers and which can increase to risk of angle closure glaucoma, especially after the removal of the natural lens. So for the management, we have to go for a careful pre-operative assessment of the anterior chamber angle. Also, prophylactic iridotomy can be done in some cases to reduce the case of angle closure, and has to be a close monitoring of intraocular pressure post-operatively. Capsular bag instability and IL decentration, again, the same thing that we have to be very careful about the IL design that we are choosing. Also the biometry, and in these eyes, usually the capsular bag may not be as strong as in the case of hemetropic eyes, and the capsule may not provide as much secure support as is needed. Corneal edema, that is surgery-related trauma to the corneal endothelium as a result of small working space. Hypermetropic eyes can also have thinner cornea, which can increase the risk of post-operative edema. So there has to be appropriate protective strategies during surgery. That is, we can use the preoperative use of hypertonic saline drops, oral carbonic anhydrase inhibitors, and we have to use a viscoelastic like a viscoat or something so as to coat the endothelium while dealing with the nucleus. Undercorrection or overcorrection can happen in hypermetropes because of the smaller size of the eye. These can lead to overcorrection or undercorrection if in case there is some remaining hypermetropia. Management is accurate preoperative IL power calculation like we have done through the ESCRS, and there has to be advanced biometric devices like the IL Master 700 and all to be used. And in case of undercorrection or overcorrection, refractive treatment may be considered. Endophthalmitis is a rare complication but serious. In that case, we have to adhere to strict aseptic techniques during the surgery. There has to be prophylactic use of post-operative antibiotics. Prophylactic and post-operative antibiotics can be considered. And prompt recognition and treatment is crucial, involving vitreous trap and intravitreal antibiotics. I think that will be all for the complications. Thank you. We can move on to the discussion, please.
Thank you, Dr. Shreya. Excellent talk. You've covered almost all the points really well. I think one of the things I can add is that in myopics, I mean, you have a deep anterior chamber. It is reasonably safe to also be slightly supracapsular when you're doing phacoemulsification. And of course, stability is extremely important. In hyperopes, you have a different set of challenges because of the extremely small eye. You need to maintain a slightly higher bottle height, and therefore you also have the challenges of higher positive pressure, etc., coming in. May I ask
Yes.
Dr. Bhupesh sir to share his opinion and any points?
Oh, I think very well covered. And as you rightly said that most of the points are this thing. I think we can emphasize on few points which are during surgery. That is to prevent as much as possible the sudden deepening and the shallowing of the anterior chamber by doing a low phaco setting and minimum instrumentation in the eye. So what I mean is that once you've gone in with the phaco, try to finish off the phaco in one go, and then probably put a visco from the side port before you take out the cannula, because at least that much time during the surgery, that compression decompression that is happening of the anterior chamber and of the eye, that can be prevented. And definitely, I would emphasize that capsular polishing has to be done, because there is no way it is a maybe it is a probably it is 100% if you can do a posterior capsular polish also, that also 100% anterior capsular polish. And as you rightly said, refractive surprise post hyperope. In a hyperopic RLE, refractive surprise, I would say, is the biggest post-operative complication, because achieving a good ELP in these patients is little difficult as compared to the myopes. Yes.
Yes.
But an excellent talk, I would say. Yes.
Thank you, sir.
So what would be your take on primary vitrectorexius? It doesn't on the, very, I mean, I'm sure it'll have its own challenges. You don't want to be probably disrupting the posterior capsule as long as you don't need to, is what I feel.
Yeah, I think I'll agree on this, because if you see the study is also 1999, so it is 25 years back. So, and probably in today's world, nobody would agree to what that study would have recommended, because definitely with the present technique and good this thing with the good IOLs, uh, I would definitely not want to disrupt the vitreous phase and cause the complications little beforehand only.
Yes, sir. They, in fact, I could find only a single study, but they made such claims that I had to like once include that, because it's a simple thing that comes in mind, that like we do a PCC in a pediatric patient, why can't we actually do a vitrectolysis in these patients where if we can judge that the vitreous degeneration is not so much, and um, that
Yeah.
has to be very controlled. Firstly, it is anyway surgically challenging.
And another thing that you said, I mean, possibly avoid multifocals or trifocals in them. I would, in fact, suggest that be very careful with case selection. And when you do feel that a case is suitable for RLE, maybe give them the option of a trifocal as well. What's your take, sir?
Yes, definitely. I mean, if there is no problem in the macula and as such, so there is no problem in trifocal, multifocal. If the patient is fitting the bill, then definitely one can go ahead and one can definitely do it.
In the
And
case of MMDs, there has to be a little like what would be your take on, if in case we really want to go in an MMD, like it might not involve the macula so much, but then there are degenerations and there are trophic patches already. So, but the macula is spared. In that case, can we go ahead with it?
No, if in case if you have a pre-existing MMD, or in case if you have a fellow eye which has got a little bad, maybe a CNVM or a, because at times they are asymmetric myopes, one anisometropic myope.
Yes.
So in that scenario, definitely don't attempt a trifocal or a multifocal. And
Okay.
as such, if we see, then these patients are, because the posterior pole is the most weakest part in myope. So post surgery, definitely the vitreous has got more turbulence. It has got more space to move around. And definitely the vitreous also, in case if the PVD has not happened earlier, then definitely the PVD is likely to happen early in these patients post-operatively. And similarly, changes in the macula is the one which is likely to affect maximum. Along with that, peripheral breaks, whenever the vitreous, this thing. So new breaks may happen, new holes may form. And so definitely if you have a pre-existing MMD or a doubt of that, definitely avoid a multifocal or a trifocal.
Okay, sir.
yeah, Dr. Shreya, what would be your ideal case for a refractive lens exchange? Which case would you not hesitate to do an RLE?
Sir,
So, Dr. Tushar, yeah, so I actually happened to listen to your talk a few weeks back, and I think when you covered Dr. Bhupesh and Dr. Om Prakash, you covered the topic very well. So, I mean, so the challenge would be in anywhere before presbyopic age. So, 45 and before, it will be real challenging to go ahead and convince somebody for a RLE. So I would say before that, in case if the patient is very motivated and if it's an anisometropic, if there's other eye is okay, so only one eye, and you cannot, because so in that scenario as such, you are not able to give that because of anisoconia. Otherwise, I would say I would still be little conservative as far as this thing is concerned. So around presbyopic age is what I would say. I would be comfortable in going ahead and doing a RLE.
Yes, sir.
Yeah. And sir, I mean, in some places there are, I mean, I wouldn't be a part of that thought school, but there are some thoughts where, it's felt that if there is a cost concern, somebody, even a high myopic, cannot afford a phakic IOL or a high hyperope. Would you consider an RLE in a young patient primarily because of cost constraints, or would glasses be the way to go?
I think I would still, cost would not be the definitely, because the patient's safety is the first thing I would say. And definitely, I mean, the procedure, now that we know what all the complications are, and uh, so definitely, still, if in case if it's a hyperopic, still you can go for it, because in such a, but definitely for a myopic, uh, I would say I would still want to go for a conservative route of convincing the patient not to go ahead with the surgery.
Yeah, I would agree, sir. I would do the same. I mean, I am also reasonably conservative with refractive lens exchange, and wherever there is another option, it's always good to go for another option, whether it's
Because usually what happens is, we go ahead and we do a surgery and we feel all is absolutely fine, and the patient, during our small follow up, like, I am from a defense person, this thing, so I stay at a place for 3 years, and then we have to shift places. So during your time the patient may do absolutely fine, but then the long term follow up is something which will ultimately, the that statistics is going to catch up with the patient, and somewhere down the line the patient is going to, and come what may, we say that the patient should undergo a routine, yearly fundus examination to look for newer breaks and then treat that area. But then the patient is also becomes complacent. It's difficult for the patient to also to remain motivated for that follow up, for that longer a follow up. So,
true even for like LASIK and phakic IOL patients. You call them every year for a retina evaluation, but
They never
you
come.
often see them once in 5 years or never sometimes.
Yeah.
yes, true. That happens. Yes.
To follow up, it's quite difficult.
Yes.
Okay, so any other points from you, sir?
So
No, I
what's
think.
your take on the peeling of the Elshnick pearls? Have you ever done it, and is it done that easily that you just wash it off and it goes?
So I would say, whatever the people have used, plain, with the hydrodissection cannula also you can go. But I
Yeah.
would say a very safe maneuver to do it is you can go with the IA also, bimanual IA. You have to use a bimanual IA in the low polish setting. And in polished settings, one can attempt it, but then again, it will be a little difficult. Some of the resilient Elshnick pearls, it will be difficult to peel them off. It's not that easy to this thing. But definitely it can be tried, but it is, I would say surgically it will be more challenging, as I have not, frankly speaking, I don't have an experience of doing it. I do normally polish all my cases, all the PCs also I polish, other than for the posterior polars and other cases. But then definitely polishing would be more challenging, and I don't know the results, how easily the cells will come off. And though it seems like on paper, it seems like a better alternative to a YAG caps, because you're definitely not disrupting the anterior vitreous phase. Your experience, Dr. Tushar, have you ever done any Elshnick pearl
I
peeling?
haven't. I haven't done any peeling, but yeah, I mean, I don't have any experience in it. But of course, prevention to the extent possible. I mean, whatever you do, even with anterior capsule, posterior capsule polishing, it is possible that you still do get a PCO. But of course, to the extent possible, prevention is always better than cure in these cases. And to the extent possible, we should try and avoid the possibility of a PCO from happening. If it happens, it happens, and then
But
I
I
think.
did talk to a few surgeons, and they were like, these pearls come out really easily. You just have to wash it off. Like, I don't know. I mean, is it okay to open the eye again? And not sure.
So if I may add, Dr. Shreya, what I can advise for somebody who is listening to this talk and wants to go ahead and do it. So you can go ahead and do it. Create a 2 side ports and go in with a bimanual IA, or with the, I mean, basic your hydrodissection cannula, and try to peel off them. In case if you don't, then as a backup, you can keep a vitrectomy cutter with you, so that in the same setting probably you can just do, because as is the patient, you've taken the patient to the OT. So in that setting, you can just do you can do a primary PCC with the cutter. I mean, though it's again, I mean, more disruptive as compared to a YAG, but then.
So in this particular study, they said that with rector access, you have to go with its mouth down in the first setting. That is, you cut the PCC, and then you have to do a little bit of anterior vitrectomy as well, so as to clear that vitreous. I don't know. I mean, if that would work a little safer, but
I
like
mean,
you said, so maybe we can do that.
and thinking about it, I mean, instead of a primary vitrectorex, you can do a secondary
Secondary.
Yes, that is
also
what I was saying. Yes.
Yeah, so I was saying
Yes.
about
But
secondary.
if
I
it's
was
going
talking
to be,
about secondary only. Yes.
yeah,
I was talking about
but
secondary
if
when
it's
you
going
are.
to be a YAG, sir, I mean, it still is going to have the same issues, because
Mm.
you are again causing anterior chamber fluctuations also to a certain extent once you're going
Yes.
inside. And of course, the PC is being removed.
Yes.
So I mean, of course, it's very hard to tell. It obviously has to be a large amount of data of anything being done for you to be for any of us to be sure. And Dr. Priya, the RD risk calculator that you showed, Dr. Tushar had
Yes, sir.
also shown in the last
Hmm.
class. So very interesting, and I think it's very good for patient education. But do we know how validated it is? What is the basis on which they've developed the calculator?
So not really. They do not give the basis, but we are trusting it as that it is from ESCRS, and but honestly, there has been no particular source that how are they calculating it, and why have they taken only few parameters into consideration, that is only PVD and this thing. So, however, it is fun to play with. I did that a lot today.
Yeah, and I think it's good to kind of let the patient know about the risks also, because
Yeah.
even as surgeons, we tend to kind of take cataract surgery for granted sometimes. And of course,
Yeah.
RLE can also be taken for granted for that matter. But of course, it's the risk of developing RD subsequently, even with a perfectly done RLE, that is troublesome with high myopes, especially.
Yes, sir.
It's good to kind of show to patients.
So in fact, we were just, for the similar age and the similar myopia, we were doing it. We were comparing the male and the female ratio, and it was just double for male.
Hmm. Yeah, because there's not so much known,
Yeah.
right? I mean, even in terms of the literature that's available, the incidence varies quite a lot. I mean,
Yeah.
having an incidence of say 1.5 to 8%, or 1.5 to 8-fold is too variable. There is too much variation between different studies. So, like
Yeah,
you
it's
said,
it's a
about the
big it's a
SDRS
big
study,
range.
so that might be helpful because we
Yes.
need large data and a good study to kind of tell us how much the risk is.
So
If I
when
may,
you, yeah, please, sir.
If I may add, so Dr. Tushar, what I found that calculator otherwise has risk almost discovered all the risk factors. Like PVD is very well understood because PVD is supposed to be a risk, protective, because you know that PVD has already happened, so less chances of further PVD happening. And then because the maximum movement of once the PVD happens, that is the time when the patient is likely to have all the breaks and other complications. So PVD is supposed to be protective, but then again, it is not a absolute protector, so as to
Hmm.
say. But definitely what they have not done is they have just simply termed the term as lattice degeneration. So in case if they can quantify the lattice,
Yeah.
suppose because some of the myopes we see lattice from 6, 7 clock hours lattice and bad lattices with multiple holes. So definitely that lattice will be different from some myope having just a plain lattice with no, no peripheral thinning, no break, no hole along with no atrophic holes. So definitely that quantification needs to be added in that, because if you see that calculator actually scares you. The moment you want to put that any value in that, it'll just scare the patient away. And so probably, because they have they have not quantified how much of lattice degeneration they are talking about.
Hmm.
So probably if something like that can be done, and further to, as you're saying, validating it, and to add more scientific proof to it, probably I think that is another factor which needs to be taken into account over and above.
There's just an option of yes and no, and not like
Yes.
how much.
Yes,
Yeah.
because that has got a bearing, because some may have just a one asymptomatic lattice. Somebody may have a rows of lattice,
Yeah.
and somebody may have a concurrent lattices, multiple lattices we have seen in almost 360-degree lattice. So definitely that patient is a risk factor, more chances of having this thing.
Yes, sir.
Yes, sir.
So good tool for scaring patients away if you want.
Yeah, it's a good tool, but definitely for scaring patients away. Yes.
I asked this in the last session also, sir. What's your choice for IOL in these cases? Is trifocal the preferred option, or EDOF, and with or without monovision? What's your preferred approach?
So I would like to go for EDOF unless the patient is really motivated and he wants to go for this thing. For a trifocal, then trifocal would be the this thing ideal. But EDOF, definitely I found them to have the best results. And because as such, if you're not doing it in a very young patient, then there's not much that you are doing. If you're doing it at 45, 50 years, you give them a micro mono sort of a vision and the patient is usually happy. But definitely one should avoid hyperopia at any cost. That is the most important thing, because they will just be awful with hyperopia. Post-op hyperopia will be just awful for these myopes.
Perfect. Thank you. And Dr. Shreya, so ESCRS calculator is the way that you would approach these patients, and is it the average that you take uh, of all the
So
formulas?
yes, sir. It's the average because it usually boils down to a single IL calculation, which has like very minute per 0.05% or something like that of a variation. So yeah, I'd go for that because instead of going for the regular ones, if you're going for Haggis and if we are going for Hoffer's question or anything like that, it's better to include all of the other formulas as well than the newer ones as well. So yeah, I'll go for a ACRS calculator.
And sir, if it's one formula that you would trust in these extreme eyes, very short and very long, what would it be in today's time?
See, I normally go for Barrett
Bad.
Universal 2, and
Yeah.
that is my go-to formula for this thing, and I've usually found it to be quite okay.
Yeah. Yeah, that's the best thing about Barrett because it works across the ranges.
Yeah, it works across the range, and usually results are okay. But you do get some surprises, as I said, because ELP is something which we are all chasing for, and it is something which kind of will surprise you in spite of whatever calculations you do. And then definitely working that the other eye, you can do some compensation, and you can again give that patient little micro monovation sort of a thing in case of a surprise. Or then you can give you can correct the other thing with a laser, the residual refraction.
And of course, in hyperopes, you don't usually have any other option also because
Yeah.
you don't have the
Yes.
option of phakic IOLs in most cases because they have narrow anterior chamber depths.
Yes.
And also, you can't treat very high hyperopias with laser. I don't usually go beyond 5 diopters for hyperopia because it does alter the corneal shape quite a lot.
Yes, precisely.
So usually, our hyperopes end up being the most likely candidates also for RLE and
Yes.
also are reasonably good candidates that way. In
Yes.
terms of myopes, fortunately, we have a lot of options, and of course, young individuals less than 40. I mean, I have a lot of hesitation in doing RLE in myopes.
Mm.
If they're eligible for anything other than RLE, laser, phakic IOL, I go for that. Otherwise, I give them the option of RLE, but on the back foot, where I kind of tell them the risks involved and hope that the patient takes an informed decision and understands the benefits and the drawbacks. And if they still choose to go ahead with it, that's fine. But usually over 45, 50, I think I'm okay with doing an RLE in myopes as well. And even there are no other options.
Yes.
So if there are no other points, so if you would, I mean, if any other points to close, and then we can wrap up.
Yes, I think very well conducted. I think both the sessions on RLE, I must congratulate you, Dr. Tushar, for the previous session also. You were fantastic in that also, because I think it was very well covered, and the PG students would have definitely, in fact, all of us also, kind of, it was good for all the general ophthalmic surgeons also. So thank you, and I think it is very well, and thank you once again, Team iFocus, for this opportunity here.
Thank you so much, sir.
Thank you, Dr. Shreya.
Sabine, are
Thank you,
there
sir.
any questions on the YouTube or anywhere else?
Ma'am, we don't have any questions right now on the online platforms.
Okay.
Then we can wrap up. Thank you. Thank
Thank
you
you
all.
so much, sir.
Thank
Yes,
you,
ma'am.
Tushar.
Thank you, sir.
Thank you, Dr. Tushar.
Thank you,
Thank you,
Dr. Shreya.
Dr.
Thank you.
Sir. Good night.
Good night.
Thank you, Sabine.
Thank you, ma'am.